So yeah, so nice to meet you guys. Alastair Yeoh is my name, and yeah, I'm going to talk mainly about about my work with MSF. I'll give you a bit of a bio of my background, and then just to kind of suppose my sort of perspectives, such as they are of humanitarian medicine and global health. I wouldn't call myself someone who's massively experienced in global health and all these things, but someone who's kind of got an interest, done some work abroad, is kind of forming my ideas and opinions about it as I choose my career path. So I'll also talk about my career and what I'm sort of thinking for myself going forward. So I see some of you are finally a med student, nice, and you're a med student as well, awesome, and people from Vienna, very nice. So yeah, I'll talk about my background. In terms of the project, first part mainly talk about that. So I'll talk a bit about the context of the project that I worked in, how I found it, and then kind of my reflections. I'll talk a bit about MSF, applying for MSF, particularly people who are interested in work for them specifically. So my bio is I've graduated from Liverpool, which is now where I'm working. I did my foundation years, for those of you familiar with this, your internship in the UK, really. And then my F3 year, which is third year of being a doctor, it's quite a common place where people take a bit of a career break or try to do something a bit different. And probably before that year, I didn't really have like a really strong, clear interest in infectious diseases or global health. And I kind of went to work in Zambia, kind of just out of interest, really, to try and work somewhere different. And it really marked quite a change in my my life, really, in terms of thinking about what became important to me, and certainly what I wanted to do with my career. So I worked in, you can see on the picture on the right, the St. Francis Hospital, which is quite a rural hospital in eastern Zambia, in this really nice, beautiful area, quite near nice safari parks. But also got kind of my first picture of seeing low resource settings in terms of healthcare and living and so on. So after that, I came back and I started to think more about doing infectious diseases and doing more work abroad. So I did core medical training, did this diploma in tropical medicine and hygiene. And if any of you have an interest in infectious diseases in the UK, and also, well, anywhere really, it's quite a sort of, I would say, well-known degree or diploma around the world. And it's a 3-month course, which I did here in Liverpool. And for MSF, that's one of the things that some form of that is generally one of the things you need to work for MSF. And that gives you a sort of grounding in infectious diseases. So after I did that diploma, that was I kind of got my first mission with MSF. And I worked in Ethiopia in 2021. After that, I've now come back to the UK and I'm doing infectious diseases training, which I've just started last week. And got something from nice, interesting. Yeah. So the background to the mission that I worked in Ethiopia was it was a mission caring for refugees. Now, this is 2020. When I first gave this talk, kind of a couple of years ago, when I came back, there was 84, the stats with UNHCR is 84 million worldwide displaced people. And that includes people who are kind of displaced within their country, and also people who are displaced into other countries, so sort of more refugees. And this was really news to me when I sort of first started to kind of understand a little bit more about this global problem. Most of these refugees or displaced people are hosted in developing countries, so countries that they themselves probably aren't situated or resourced financially, infrastructurally, to even look after, sometimes provide even good healthcare for their own citizens. Nevertheless, other people coming from elsewhere. So I think that there can be people who don't know much about the state of refugee problems globally. There's this perception that refugees is a problem of people from low-income countries coming to high-income countries. And whilst that is a part of the problem, it's by no means the biggest. And actually, most people are fleeing to their next door country, for some safety, security. But this was 2021. A year later, 103 million people forcibly displaced worldwide. And as I'm sure many of you can guess, a lot of that is driven by refugees from Ukraine, but not all of it. But yeah, a significant amount of that will be that. But it's just to show that this is a really the kind of whole background to the work with MSF, and a lot of the work MSF do, is this refugee crisis, which is, it's probably something which is going to get worse, over the years. It's something we need to be really, I think, take very seriously. Why is it going to change? It changes when disasters happen. It changes when the globe, the climate changes. Lots of places that are habitable are likely not to be habitable. So this is something which is, I think, is going to change. And as a sort of I suppose, as a global civilization, we need to be really turned on to how we're going to care for these people. So that's kind of the background more generally. In terms of the place where I was working in a place called Gambela. So this is a map of Ethiopia. It's in Eastern Africa. You can see in the west of Ethiopia, it borders South Sudan. And there's an area called the Gambela region. And these are all numbers, quite old numbers, probably a couple of years old now, of numbers of refugees. So in Gambela, there's over 300,000 refugees in that area. It's huge, huge numbers. And these people coming from South Sudan. And a lot of these people are displaced because South Sudan has had a very challenging, I don't know how long really, but certainly in the last few decades, there's been, it used to be Sudan and South Sudan. South Sudan seceded from Sudan. And when they gained independence, there was another civil war within South Sudan. There's still ongoing fighting, although not maybe technically still war going on, but there's still a lot of fighting going on between the various groups within South Sudan. And for a lot of those groups, it's just not a safe place, and there's not, there's a reason why people are fleeing that area. And there's also natural disasters like floods, which is another reason people leave. And a lot of them flee into Ethiopia. So they flee east and just walk, huge distances often across the border. So this is a typical story of one of the camp residents, and I'll just let you read it. Yeah. And so, these extreme, very extreme situations these people are in, and often it's young women with children, often is sort of the larger proportion of people there. This is kind of the Google Maps of where we were, and this was the camp that we worked in. So Kule refugee camp, this was one of a number of camps in that area. Our population of this camp was 60,000. And most of them are women and children. 65% of them are under the age of 18, and the vast majority of the residents were South Sudanese refugees, as I said, but of this particular ethnic group, the newer ethnic group. And there was quite a lot of conflict between different ethnic groups, and this happened to be one of the large ethnic groups which was displaced because of the fighting. And in that camp, there's actually there's a lot of different actors, one might say, or agencies operating. So actually, what's kind of interesting about this particular emergency is that this huge refugee population has been there for 5 to 10 years, rather more than 5 certainly. So the project I was working on, they had been there for 7 years. So this is kind of an example of a kind of chronic emergency humanitarian problem. So these are people who are kind of in waiting, really, that they want to go back to South Sudan. So there's some number of people who are wanting to kind of move into Ethiopia, but actually most of these people just want to go back to their homes, but they're just waiting for things to be stable enough and safe enough for them to do that. And so this is an example probably of a humanitarian situation that has developed over a number of years, and over that time there's a certain sort of humanitarian infrastructure that has developed in this case, where there's a number of different organisms working together to provide, still not actually very much in the grand scheme of things, but hopefully just enough to mitigate some of the worst effects for these refugees. So the kinds of organizations that were there, the WFP, the UN Nations World Food Programme, providing most of the food, Action Against Hunger as an organization which primarily looked at malnutrition and trying to reduce rates of malnutrition in the community. Oxfam were doing things like, I think, water, sanitation, hygiene in the camps. MSF, when I was there, so we were doing the healthcare. So we were providing actually just healthcare for the camp. And actually, we probably served a population that was well over 60,000, because places from all around camps, people would walk from other camps many miles often to come to our facilities, and because they were better than the others. And this kind of humanitarian problem is maybe in contrast to different kinds of humanitarian. So, you know, for example, if there was a tsunami or a flood, then that would be sort of be in much more early stages, and there maybe wouldn't yet be this level of infrastructure in that setting, which is not to say that it was completely organized, but yeah, it's just kind of, I found it very interesting actually going there and seeing, oh, there's all these different actors all trying to fulfill a different part of the needs of the community. And to kind of, what are we talking about here is humanitarian aid. So it's kind of interesting to maybe draw a distinction between humanitarian aid and development aid, and to kind of have a bit of a distinction between those two things. So it's a spectrum, but on the one side, you might, take your example of, the war and people immediately displaced, or like the flood, the disaster, which means that there's a kind of a short-term stressor or short-term issue, and there's a very specific crisis. And in these situations, this is a lot of what this is primarily MSF's mandate, is to provide humanitarian assistance, and it's focusing on really just trying to provide, to save lives acutely, and to mitigate the worst effects of these kinds of problems. And you kind of contrast that to other aspects of global health. It's a big umbrella, and many things could fall into that. If we're talking about aid, or you could use the word development, you might not use the word aid there, but like there's lots of programs where, for example, you're trying to improve a hospital or improve a healthcare system in a low-income country, and you're coming in from a higher income country to try and do that, or try to interface in a way that develops the kind of existing healthcare system. If we stay within the healthcare umbrella, trying to develop the existing healthcare system, that I would say is more on the development side. And this might be more about trying to change systemic things about the infrastructure, about the healthcare, to try and improve things in the sort of longer term. And this is kind of these two paradigms are kind of a bit different, and they have different pitfalls, different, I suppose, things one has to be sensitive to. And what work I was doing is very much more on the humanitarian side. And I'll talk a bit more about development later. So this was the camp I worked in. This is a kind of a shots I took on one of my first days there. This is us within the compound, looking out into the structures and the camp. So our health centre was situated right in the camp, and as you can see here, these structures are kind of not massively dissimilar to the kinds of structures that and the kind of houses that people would have lived in back in South Sudan. So people were able to build structures within defined zones that were kind of a bit like maybe what they would have back home, and so kind of had this semblance of a sort of village feel, really, in contrast to some refugee camps which maybe have a different. Obviously, this is one that's been there for quite some time. So looking out there, you kind of might not look that dissimilar to what a village in South Sudan might actually look like. Apart from you can see tarpaulins from the UNHCR, you can see peeking through the thatch roofs and things. And in contrast to this, this was this is the main camp area, which had time to develop and had a bit more kind of order and stability to it. This was a place called Pagak. So this was a place in the reception area. So to come to be accepted as a refugee into one of these camps, there was a process by which people would have to come to a holding area, essentially. And for reasons that are completely understandable, but also quite sad, people come, and there's not always the processing of people being accepted or not as refugees. They're waiting somewhere until they get that pass from the government agency. And in those places, in these holding areas, there isn't much, if any, very, very little provisions made. And this was a place called Pagak, which was on the border. And this is, you know, by a country mile, the worst conditions I've ever seen people living in. It was really, really awful. And these are all pictures from the MSF website. These aren't ones I've taken myself. And you can see, you know, that the hygiene conditions here were appalling, so bad, and they didn't have, you know, they really struggled to get adequate, you know, just sewage and kind of the clearance of waste. And people were, you know, the rates of sort of diarrheal and illness and things were massive. And, you know, the mortality rates in these areas were really, really, really high. And so it's, you know, this is a kind of I guess kind of highlights what it would be like if there was little or no provisions for these people. And even in the camps, things could be pretty dire. So the camp, the health center I was working in, this is you can see the map here on the Google Maps of it on the right. So if you can see my cursor here, this is the whole health center. And some of the main buildings, where some of the main wards and buildings are these sort of tin roof structures. And we did a lot of inpatient care. So we had about 90 beds or so, including, so we had adults, inpatients, pediatrics, neonates, which was twinned with the maternity unit. We had some beds for people with TB who were sort of isolated. And there was a lot of outpatient care going on. So there's like hundreds, or maybe even I don't know how many consultations they would do a day, certainly in the many hundreds, if not thousands. There was also care for safe abortions. And this is actually a really big thing in these camps, you know, providing safe abortion care for people is really, really important. And providing sort of contraception for women, so they can kind of be in control of their family planning is also really important in these settings. And we also provided vaccinations and care for some sort of psychiatric care for some people, and care for victims of sexual violence, which was pretty common. So in terms of the medical side of things, I know a lot of people are kind of medical in this group. So within each sort of ward, within the adults, you're going to see, you know, sort of loads of fascinating things, loads of tropical disease, loads of infectious disease, a lot of also things that you just see in the UK as well, or anywhere else, just the nuts and bolts of general medicine. Quite a lot of fractures and lots of, you know, people falling out of trees, or, you know, whatever, you know, there's lots of children. So, you know, children having fractures is common. Lots of neonatal problems. So the maternity care was obviously a far cry from what you would want in that sort of setting. So there were lots of problems with neonatal problems, birth asphyxias, and, you know, sort of hypoxic ischemic encephalopathies and those sorts of things, and neonatal sepsis. We saw obviously a lot of tuberculosis. You know, it's pretty rampant in these kinds of settings, and of every form you could imagine. So what do we have in terms of resources then? So we had, in terms of the investigations that you obviously have your clinical history in your examination, which is obviously first and foremost if you've been to medical school. And that was, everyone spoke to the kind of staff groups that were there. There was the international staff, which was actually very small contingent. So international staff there was myself and maybe 5 others in the camp who were, 5 to 10 who were international staff. The vast majority of healthcare provision was made by Ethiopians, so national staff. And also we employed newer people, so people of that tribe that we were caring for as translators. So there were people who were helping us to take history and you know, and speak to the beneficiaries, the residents of the camp. So in terms of other investigations, we had really very basic. So you'd have you maybe have an HB sometimes, not always. We had glucometers fairly reliably. urinalysis, there's lots of rapid tests, extremely useful. So, you know, your HIV tests, hepatitis tests. Leishmaniasis was not uncommon, so quite a few cases of that, which is probably something you very, very rarely going to see anywhere, you know, certainly in the West. Obviously, loads of malaria, so your malaria spot tests and your malaria blood films, super important there. And you could also do testing for fluids. So, you know, your microscopy, you could, you know, looking at sterile fluids, CSF, acidic fluid, and looking for cells and these sorts of things. So actually, you know, with very little, you can do quite a lot, fair bit. You know, it's obviously not as much as you want to be able to do, but, you know, yeah, surprising how much you can do with just a few basic tests. Also, an ultrasound machine. This is something that's kind of comes MSF are quite is actually extremely useful in a lot of ways in sort of resource limited settings, because you can, there's so many potential applications of using ultrasound. Another thing we had was telemedicine, which was really something I used a lot and found very helpful. So we had access to some specialists who usually were people who had worked in they usually, you know, medical, you know, doctors of whatever specialism who maybe worked with MSF, had some affiliation, and they would give sort of MSN Messenger style, or I should say Facebook Messenger style advice to depending on how old you are, might know what MSN is, to people. So you could ask, you know, I've got this patient with this is, and they maybe give you advice, which is incredibly useful. We didn't have really organ function tests readily available at all. And in terms of treatments, you would have the basic kind of first rung of a lot of your basic groups. So you're going to have some broader spectrum antibiotics, some narrow spectrum antibiotics, TB medications, yeah, and all the various bits you can see there. Oxygen a little bit, but not that much. And we're using using oxygen concentrators to try and get, you know, just a little bit of oxygenation, but not much. And obviously you could do drains, so you could chest drains, you could do acidic drains, you could aspirate joints, you know, you could do things like that. For anything that was more complex, we would, so for example, if there were surgical problems, obviously we couldn't do surgery there, we would refer them on to the government hospital, which is about an hour down the road, where people would get quite, and that was in the nearest town. So the nearest town where we were living was called Gambella town, and they had a surgical centre there, which people got very variable care, honestly. This was a government-run hospital in a not very rich part of Ethiopia. So, you know, our kind of beneficiaries would get some care there, but it was very hit and miss. But that's where they needed to go if they had an urgent surgical problem. So a bit more about my role there and what I did. So my role was really split into sort of three major parts: clinical part, training, and also management. So interestingly, I think when you there's lots of different types of roles that MSF might have, but one thing that I hadn't maybe expected, but I think was was the kind of the managerial aspect of was the managerial aspect of it. So as well as all the clinical stuff, there was also some other things, you know, which I'll talk a bit more about, but wouldn't necessarily be the case. It depends on what kind of mission you're on. Some missions you'd actually be more purely clinical, and some places are actually looking for someone to do a bit more of the managerial side as well. So in terms of the clinical side, I was functioning as a doctor in the health centre, and we had, in terms of medical doctors, we had 3 or 4, including me, max doctors, and we had a lot of clinical officers who essentially function as junior doctors, and then we would function as the more senior doctors. So yeah, did ward rounds, we did on calls, all the sort of stuff you would usually imagine, deciding who needs to be referred on to the other services. And I think one of the big things that you bring clinically to any of these sort of more chaotic environments is, as well as your medical knowledge, which I think for me, my general medical knowledge was decent. I had a lot to learn, and still have a lot to learn about a lot of the tropical stuff and things I don't see very often. But actually, you know, the staff there did have a lot of knowledge there. So actually, it's a very different I think, a very different model of working than we're used to in high income countries, where one person at the top of the chain kind of knows everything, well, how it's supposed to be. And then the next person knows a little bit less, next person knows a little bit less. Here, actually, you kind of just have to kind of take the knowledge from different people, and it's a bit more of a patchwork of competence that you use. So I would defer to a lot of the local staff about things I wasn't that familiar with. But one of the things I think you do bring is actually a good understanding of how healthcare should be provided in terms of structure, in terms of standards, guidelines, just more general things actually about how you should run wards and stuff, that I think, because you're used to working in a system that's very organized and orderly, you actually can try to emulate that to whatever degree you can. And actually, I'd say that's a really big thing that you bring to these kind of, people from a higher income setting going to a lower income setting bring to the clinical work. Another big thing was training. So we tried to do training. We did training with trying to do regular training with clinical officers, and I did some ultrasound training with the local doctors as well to try and leave some skills there, which is obviously a really important part of anything one does in a lower income setting, is to do with capacity building. In terms of the management side, so things like, this was some sort of more managerial stuff to do, doing the rotas, blah, blah, stuff like that, not very interesting, but also stuff to do with the, how do we optimize the medical services within the camp. So, we had lots of problems with pharmacy. So we had, problems with drugs, not having enough drugs, and trying to decide, all right, we've got a shortage of this drug, this drug, this drug. How are we going to ration and optimize our use of what we have left? And so that obviously was a bit of an intersection between having a clinical understanding and trying to coordinate and manage the project. My sort of daily routine. This is a shot of the table I used to sit on with my AeroPress coffee every morning, and you can see the sort of camp. I don't know if I've got a picture of my room in this. Don't know if I do. I don't think I do. But the accommodation was fine, really. It's just like a simple room. But yeah, it was basic, but fine. So every morning, I would have a look at the seeing which patients were in the camp who might need to be reviewed and go on to another hospital, the one nearby, do a ward round and so on, and then maybe do some other managerial stuff or teaching or what have you. So I'm going to talk just about a couple of cases, really, that kind of, I think, illustrate, I suppose, give a feel for the kinds of things that you see. So this was a case I remember coming onto in the morning, and there was a case being administered overnight, and the sort of working diagnosis was seizures. And then I went to see this boy who was probably, I think, 10 or 11 or so, and then he was kind of just like twitching and kind of having these I suppose spasms, twitches, but it was a bit strange. It didn't really look like a seizure. If anyone can guess what the diagnosis is, then you get extra points. Basically, he wasn't having seizures. He was, every time you kind of move him or try and interact with him, he would spasm like this, and he was clearly awake. So, one of the key things you probably know about seizures is if you've got a seizure, then you're unconscious. Having a generalized seizure, you're unconscious. But he was not. He was actually awake whilst having these sort of whole body spasms and locking up. Does anyone know what this might be? And he was very sick. He was really sick. Yeah, exactly. Yeah, something tetanus. Exactly. So this boy had tetanus. So the story was then also that he had, maybe had there's lots of wounds on people's feet, and things, very easy ways that this can enter in. And this is a really awful, awful condition. Now, in the UK, you see maybe probably less than 5 cases of generalized tetanus. But yeah, this was it was really, really difficult to manage. He was having really severe whole body spasms. Obviously, a lot of things that one might want to do for him were not available. We were trying our very best to give lots of benzodiazepines and diazepam and so on to try and limit and control these spasms, but they were just getting worse and worse and worse. Obviously, we were treating him with whatever other measures we had, antibiotics, immunoglobulins, and so on, to try and help. But unfortunately, over the course of 24, 48 hours, it was getting worse and worse, and unfortunately died. And it was very, very sad. You know, this is a disease which is essentially eradicated in high-income countries because we have a very good vaccine and we wear shoes, and you know, there's lots of this is just such a typical example of really a problem which can be, you know, fixed and resolved by very simple measures like a really robust vaccination program. But without that, you know, you have these really, really awful cases, and there's about 200, 300,000 deaths reported by tetanus worldwide per year. And this is something that we can really fix. And I think, you know, that's one side of working in a humanitarian setting, is you're seeing cases where you have to come to terms with the fact that people are dying from really treatable problems. And that comes as on the one hand, that's really, really sad, really difficult to see, but on the other hand, it's like a massive incentive to try and improve things. And I think seeing that is important. Another case I saw was a boy. He was much younger. I think he was 3 or 4, and he had a sort of a putative diagnosis of gastroenteritis. They were planning maybe send him home, and I kind of went and saw him. I thought he looked a bit sort of lethargic, a bit tired. Went to have a look at him a bit more, examined him in a bit more detail. But probably he had a bit of ascites, but fluid in his abdomen, and scanned him. He did have ascites. Talked a bit more about the history. There had been some exposure to tuberculosis. Let's see where this is going. We took some fluid sampling from his abdomen and found that he had lymphocytes and cells in there, and essentially, made a probable diagnosis at this point of tuberculosis, and started him on the relevant treatment. And we had a program there where we could do outpatient treatment. The treatment, as you may know, for TB is often at least 6 months. And so we kind of send him away on this treatment, kind of just hoping that that's the right diagnosis. And then I remember seeing him a few months later in the clinic. I just happened to be, saw him, and he was just way better. He was just, bright, happy, shy little boy, and gaining weight, just looking so much better, and just like a healthy boy. And it's like so obvious, clearly diagnosis was right, not a wonder diagnosis by any means, really common condition, but it was just such a, and the mother was so happy that he was well, and so on. So this is the kind of the other end of the spectrum of, this is what happened. Simple things can really make a difference, really save lives. This wasn't a complex diagnosis, it's not a complex treatment, but it can make a huge difference. So a bit more about the life in the camp outside of work. This is a picture on the right. There's a picture of myself, a lot of the national staff, Ethiopians, and then a few of the staff from international staff. So some were from Canada, Germany, Pakistan, Bangladesh. So kind of a real mixture of international staff. I was the only person, I think, from the UK. And so every now and then we'd have barbecues or whatever in the evening. So there was like a social aspect to it as well. There was lots of lovely wildlife, lots of birds if you're into your birding, and some less nice wildlife. This was I don't know if that was a black mamba or not, but there were some rather scary snakes around as well. And one day, so about 6 months into my time there, we had an unexpected letter arrive from the government. Now the letter basically was a letter telling us to stop everything we're doing, close the health centre, stop doing all your outpatient work, just stop all activities for our for MSF we're doing in the region. And this is basically like someone coming up to your hospital and just closing the doors, kicking everyone out, closing it. It's like crazy, but this was the letter that we received from the government. And the context for this is that, as some of you might know, this was in 2021. There still is, but there was certainly at the time, over the preceding year, conflict in Ethiopia, predominantly in the northern territories of Ethiopia. There's conflict between the Tigray, sort of TPLF, and I won't go into all the details, but there's a group within the north of Ethiopia that, to kind of reduce this, make it simple, trying to secede and try and secede from Ethiopia proper, and there's a conflict, civil war going on around that. Now, MSF, so our project was not there, but MSF did, our section of MSF did have operations up there, and they witnessed the Ethiopian government killing unarmed people, whether they were combatants or not, I'm not sure, but anyway, there was essentially MSF witnessed, the Ethiopian army killing unarmed people, and made a statement about that. Now, this is now coming into the kind of complexity of working in the humanitarian space in countries, and this is all, I suppose, theoretical. This is my interpretation of the events, and maybe not what this is not some absolute, but it was pretty likely that the reason so that we were now being ejected was because MSF had spoken out and spoken publicly about what they had seen, we had seen as an organization in the Northern Territory. And one of MSF's main mandates is to speak out against things and to advocate. So advocacy, témoignage, is one of the big tenets of Médecins Sans Frontières, and it's a really interesting thing, because it's a really important function that serves. But you can see that being there and speaking out against these things also can really compromise the other operations that you have in the country. So suddenly we are sort of persona non grata, not really wanted there, because we are speaking out against the government, and they don't like that, and they want to remove us. And then this has a knock-on effect on the community that we're trying to serve, nothing to do with the conflict in the north, and they're now telling us to stop our activities. It's really, really difficult. So we had to comply, that you have no choice. If you don't have a mandate from the government working with, you can't continue operations there. It's just not possible. And it was a really difficult time. We had a very short time frame to close our clinics, and then basically try and figure out how we're going to empty this hospital. It's small, but still, got quite a lot of people there, in a way that's going to be the least harm. And bearing in mind, you've got a lot of patients on, you had diabetic patients on insulin, you had patients on TB medication, HIV medication, all of this, healthcare is like a moving train. If you stop it, it's really, it's really, really massive consequences. And we also had to think about, trying to do that in the way to mitigate damage as much as possible, and also in as safer way as possible. Bearing in mind you are in the middle of a camp, trying to close it in a way that is safe, and so that was a very strange time. It's not what I was expecting, obviously, going on my first mission, and we just tried our best to do it in a safe way as we could. And the kind of, I suppose, heartbreaking thing about it was that the community were actually quite understanding. Like, you could imagine being in this community, you're living there, and then suddenly the hospitals, all the hospitals, healthcare services close, and they didn't turn against us. They kind of understood that this was the government, as we were trying to explain to them. It was the government that was preventing us from working there, and it wasn't our wish to leave. And they, and then we had to stop our operations there. Now, then we've entered it, and then there was this period of negotiation and so on, and things changed. And actually, since about 6 months later, 9 months later, after negotiation and various other things changed, and we managed to restart some services. So MSF had to accept that, okay, we have to move out at this point, but they still wanted, obviously, to be able to return, and then they have started to, for quite a while now, they've been working there again. But I think it illustrates the kind of, I suppose, the political interaction of humanitarian work, and also the kind of precarious nature of these projects. So that was like very, very difficult difficult thing, but really glad that, the services are resumed there as well. So my personal reflections really on the work, I'm going to talk a bit about the work, and my reflections kind of more generally on global health, such as they are. So I think one of the key things, if you're interested in working in this kind of setting, is on a, I say clinical and also more generally, but certainly clinically, there's a lot of living with uncertainty. So you're living with the uncertainty of, is my diagnosis correct? Is my is my treatment going to work? There's a lot of uncertainty in terms of, diagnostically, therapeutically, whether your decisions are right or not. And you have to kind of, I think, learn to just accept that that's not a personal failing, but that's just a feature of working in that kind of environment that, certainty is difficult to find. And another thing is finding your role. So I think particularly within my experience of working at MSF was that I was used to being in jobs where I knew exactly what my role was, very defined. Someone would say you could do this, this, this from this time to this time, and then you go home. But I think in this kind of setting with a bit more sort of, I was like chaos really, isn't it? Less organization. There is, you have to kind of find your role, play to your strengths, and try and work out how you're going to, try to have an impact while you're there. And I mentioned this before, the fact that you're working with a patchwork of different competencies. This is really, which was really clear to me, that it's very important, I think, whenever you work in another context, that you're coming in with a certain set of skills, which they might not have, but whoever's working there certainly have a lot of skills that you don't have. So it's important that you need to come with an attitude of humility, but also not to disregard the skills that you might have to bring to the situation, and then trying to work with the different competencies within the team to get the best result, I think is one of the really key things about this kind of work. And I think also relies on good leadership, really good communication, obviously, is really the core. It's difficult leaving and also difficult returning. So for me, I left at a time when I was just getting into fairly new into a relationship with my still partner. That was really hard, leaving, not knowing how things would be. And whilst leaving was difficult, I think returning was also very difficult in other ways. So I think coming back, I think my experience both being in Zambia and certainly being in MSF was being somewhere where you're seeing real extremes of suffering. One thing I didn't mention actually earlier was there's lots of children with malnutrition, which is a really hard thing to see, and is also, it sort of deserves outrage and a real really strong emotional response to see that. And I think most people will feel that, seeing children dying of starvation. It's really awful. And coming back then to the UK and then seeing, you're in Tesco and you're trying to choose 10 different types of apples, and you're just like, these two pictures of the world are just totally different. I just can't put them together. And you just like, it's very easy, I think, to, or rather I'd say it's difficult to kind of come to terms with that, I think. And I think that's one of the things I'll talk a bit more in a second. I think it can be life-changing. I think working in any low resource setting, I think is life-changing, because I think, I'm not, and this is not for me to say that I'm some expert or, someone who's seen it all, not at all. But I think even my, what I would call minimal experience of having worked in Zambia and also at MSF has given me some insight into, when you're seeing things on the news and you're saying, oh, there's a famine in here, there, or the other, kind of having some actual first-hand understanding of the human suffering involved with those problems, or people dying of malaria, tetanus, is I think has definitely changed my life in terms of what I want to try to prioritize and what I want to do with my career and so on. And I count that as extremely valuable. But I think with that, it's also quite important to try and cultivate an optimistic view. I think it is, when I came back, certainly it is, I think you often have this clash of being somewhere where you're seeing extreme suffering and then coming back and being like, what are we doing over here? How how can there be people starving in one country and people, with obesity rates of a third of the population in another? How can this be the case? But I think it's important to be, there's kind of I think it's difficult to live in that constant state of outrage, although some people do. But I think, everyone has to find their own way through that. And for me, I found it useful to kind of also try to cultivate actively optimistic view in terms of focusing on the real capacity for improvement that there is there, and I think it's good to recognize that 100 years ago, there was no such thing as humanitarian medicine, nor would anyone, and now there is, and there has in many domains, one might imagine, as the world's expanded, as we've understood more about people distant to us, there has been, we have to we're relearning. I would say that we are in a stage of relearning our ethics in terms of, our kind of intuitive ethics, I think, for people on an emotional level come from people that you see and you interact with on a daily basis. And if you go back hundreds of years, hunter-gatherer, whatever, that makes sense. Having your ethics based on your emotional responses to people around you makes sense. But now we live in a world where you're having effects on people you can't see, that you don't know, that look different to you. And we need to learn to update our ethics to match that. And I think it's important, for me at least, to be optimistic that we can move in that direction, that we can become more ethical and more aware of problems in places distant to us and in people different from us. So that's kind of something that's important for me. In terms of more general reflections on global health, I think it's always important to mention how complex it is to interact from a high resource to a low resource setting. And this is even something more general to say about when there's someone with a lot of power, someone not a lot of power. Whenever there's that dynamic of high power, low power, it's complex. And I think particularly in terms of healthcare, if we just focus just on that, delivering healthcare, coming in and parachuting in a pre-built hospital to a country can be good in some ways, but also there's a real risk in terms of how you do your intervention in another system, that you could undermine the development within that country. For example, if you're delivering healthcare, if you just go and deliver all the healthcare yourself, then actually you might be stunting the growth of an actual locally driven solution and locally driven development of infrastructure, which actually in the end is really, I think, what we're understanding more and more is what you need to be doing is trying to create a contextual, coming in from another setting, you're not going to have a contextual or cultural awareness necessarily that you would really want. And it's important that you've always got that in mind, that you're trying to build the capacity of local solutions and local people more generally than trying to just parachute in your solution imported from another country. And that can be really complex. But I think it's also important to say that stepping away from that problem entirely, I would say, is probably an even worse response. Some people would say, oh, it's too complex, you shouldn't interact with lower income settings, you shouldn't try and extend any assistance because of this risk of neo-colonialism, what have you. But I would probably say actually that's, for me, stepping away entirely from the problem is even worse than I think you should try and engage with the problem, but in a sensitive way, bearing in mind there's lots of pitfalls. And also, talking a bit about humanitarian medicine more generally, we talked about what are the kind of effects of humanitarian action. I think there's there's obviously the actual lives saved for the people there, the suffering that's mitigated by the actual operation on the ground. And that's really, really, really important. There's also a really important effect of advocacy. And I would say, talk a bit about MSF as an advocate, as advocacy being an important part of their their structure, their sort of mission statement. But to kind of say to the world, look, this is what's happening here. This is MSF are in a situation where they can say, look, there are people here who need our help. We need to pay attention to this. And MSF have a huge voice in the world, and they're a well-known organization, and people listen to them. And that is actually huge. So that's huge in terms of lobbying for direct assistance, in terms of fundraising and so on, obviously. But it's also just, increasing this global awareness and global conscience that we should have of, look, these are problems we need to pay attention to. So that's another actually really important aspect, I think, of humanitarian work that shouldn't be that goes also with the actual patients that you look after on a day-to-day basis. So for me, my reflections after all of this really is, deciding for myself, or what do I want to do going forward. Now, I think for me, there's kind of three core elements for me. I think I've chosen a specialty in the UK that's kind of relevant to global health. That's why I'm doing infectious diseases, because I perceive that that's going to be a specialty which is going to give me open potential avenues for me to have an effect outside of a high income system. So whether that would be in, I'm planning to be involved either in research, or so, whether there's sort of low income relevant research that I could be involved with, or in policy. So there's lots of room for people who've developed an expert knowledge, say for example, tuberculosis, for example, who might be able to help with supporting local programs and so on. So for me, I'm actually really in the stage where I'm investing time in working in the UK, but this is my sort of long-term goal, to try and think, as I go along, what opportunities can I seek out that might help me to have an effect beyond working in the UK. But yeah, and I'd also say that for me, I don't think it was, there were times when I considered doing that more, but I don't think I could see myself being a long-term MSFer every, just going from mission to mission, always working abroad. And I think it's important to recognize that. I've really enjoyed it, and I would probably I do want to work abroad again, but I think I also want to have, a family and these other things, which actually, that's why I think for me, this path, working in the UK, is better. And actually another really big part of what I suppose my response and my kind of going forward is effective giving. And I don't know how much you guys are talking about effective giving. I'm sure a lot of you are familiar with effective altruism and the basic tenets of that. But I founded with some friends of mine, some colleagues, an organization called GiveHealth. And this is similar in some ways to it's essentially a pledge of, we're a community of healthcare professionals who pledge to donate at least 1% of our income to effective global health charities. So we, it's a giving pledge, not dissimilar. Some of you may have heard of Giving What We Can, but it's a giving pledge where we want to try and encourage other healthcare professionals. So these really are the people that I am interacting with, seeing day to day, and have access to say, look, to kind of, I suppose, spread the message about how effective giving can be. And I think it can be extremely effective. I think about what I can do as an individual person, being a doctor on the ground, and what I can do from earning in a high income setting. I really very strongly feel that actually what I can donate is going to be a massive part of whatever I do with my career. So at the moment, I donate 20% of my income, and I've started this organization with some friends, and we're trying to create that culture of effective giving, particularly in healthcare workers who often kind of understand how important healthcare is. And a lot of people work in healthcare want to make a difference in low income settings, but they don't really know where to start. So I think this is part of the growth of that. So further reading, so things that I think if you're interested in working abroad with MSF, Band-Aid for a Broken Leg is a really nice first-hand account of what it's like doing their first mission. This guy, Damien Brown, who's from Australia, his first few missions with MSF. James Orbinski's book, Imperfect Offering, is a bit more about sort of background of MSF and more sort of bigger picture stuff. It's quite a heavy read, but really, really interesting. And Doing Good Better, you may have well heard of, which is a lot to do with effective giving and the principles of effective altruism. If you're interested in volunteering, so a few quick plugs. There's a website my colleague made called Volunteer Global Health, which has opportunities for volunteering abroad if in a medical capacity. In terms of working with MSF websites are really good, and they have a lot of information on what you would need to enter MSF to work with them, and the various kind of roles that are available. And it's not just doctors, there's actually loads of stuff you can do with MSF that isn't directly medical. And those actually other parts of the organization are incredibly important. Although it is called Doctors Without Borders, it should just be people with that, not just doctors. And yeah, I think there's lots of ways that you can make a difference, whether it's actual direct work, what you do with your career, but also the effective giving side. And then you may have also Giving What We Can. So that's a pledge of 10% of your income to effective charities, and you know, I encourage anyone, you know, to look into effective giving as a really key part of what you can do to make a difference, as well as my organisation GiveHealth. So does anyone have any questions? I've just been talking straight for like a whole hour. My throat's sore.
Thank you so much. I'm just going to pause the recording for the questions part.